Good evening. Welcome back to my IVF Answers. We are back once again. You can see our special guest is with us already as well. Professor Evangelos Papanikolaou is with us. So I'm really happy and excited to have you back. How are you? Hope you are doing great and are ready to educate us and answer some of our questions as well.
Caroline, I'm so grateful for this invitation, and I'm really amazed how a non-profit organization like your organization has such a good motivation and has such good organization for these events. I really envy you.
I'm really happy to hear that, and we are definitely happy to have you back. I don't know if you had a chance to have to be here before. Actually, Professor Papanikolaou had the chance to already discuss this topic because we already talked about IVF failure after failure. We were talking about recurrent implantation failures as well in the past. I remember that you have been a part of our mission, let's say, quite a lot as well in the past. Like I think it was even 5 years ago that you joined some of
Yeah.
our events. So I'm really excited to have you back with us. This is a difficult topic to discuss for sure. And before we start, let me just explain to everyone that we will start with the presentation on our topic. So Professor Papanikolaou will first explain the main causes of IVF failure, but of course he will also discuss possible options that are available, that are of course possible for you to let's say have a chance successful pregnancy. But all afterwards there will be time for your questions. So as always, please remember to put the questions in the chat, and Professor Papanikolaou, I'm sure, will be happy to answer any of them. This is a safe space. This is all anonymous, so I can only encourage you to take part in it. And I'm sure you will have plenty of questions, so you can start typing them right now during the presentation or afterwards, of course, as well. And let me just introduce Professor Papanikolaou is the co-founder and fertility specialist with years and years of experience at assisting nature. So we are definitely happy to have you back. And are you ready to start?
Yes, I'm ready. Show me the first presentation. And as the title explains, it's one of the most difficult time for both of us, for patients and for doctors, once we have to discuss failure after failure. And of course, once you have a patient that she's still young or the infertility is quite mild, the infertility reason, I mean, okay, we both have the time and to explain and to understand each other. But once this failure might be the fourth failure or the third failure, then things becomes difficult. So what actually is the definition? It's very complicated because all of us, I mean the scientific community, we have difficulties to find a common way for such difficult definitions. However, it seems that we accept that once we have transferred more than four good quality embryos in women under 40, then it means that this is a repeated implantation failure. So this is the definition that stands for the moment, and probably I'm happy with this definition because someone could say after 3, someone could say after 6. I think within 4 good quality embryos, you should have at least one genetic euploid embryo, so it might mean something that after 4, transferring 4, we haven't achieved still a live birth. So let me summarize. There might be many reasons, but you have to remember that 90% is the embryo. So only 10% are the other reasons that I have mentioned here. Mainly is the embryo. So probably we are losing our time once we face these discussions with the patient when we haven't performed preimplantation genetic testing. So in the era of not testing our embryos, maybe it's not a real deep discussion. However, we should, as doctors, we should always not forget that this 10% is still 10%. So the main reasons of this 10% is anatomical abnormalities of the uterus, mainly congenital septums or fibroids or polyps, endocrine factors, although we have checked sometimes our prolactin or our TS thyroid function, always there are months that our thyroid is not functioning well, just for emotional reasons. Immunological factors is very difficult really to say that you have autoimmune disease or autoimmune predisposition, but definitely there are patients that they are difficult to accept foreign bodies as it is the embryo, especially when it's coming also from egg donation. So it's both sides foreign to my body, to my immune system. Thrombophilia also is important, 1 to 2% for repeated implantation failures, mainly for recurrent miscarriages, but also for failures, because if we don't, in some centers, they don't test the ACG very soon after the transfer. In our clinic, we always test it 9 days after the embryo transfer when I'm talking about blastocysts. So immediately we know if we have a biochemical or not. The genetic analysis of our microbiome, it seems that it's not a marketing tool. It seems that has an important factor. And last, I don't believe so much because there is overdiagnosis, is chronic endometritis. We need to take specimen of our uterus lining in order to define this, but the problem is that the majority of the anatomopathologists, they're not experienced, they're not fertility pathologists, so the majority of them, they see just always they see endometritis. It's like the test pap. Almost always they mention cervicitis. It does not mean that we have to cure it. So how can we act once we have a repeated IVF failure? So the first thing that we have to discuss with our patient is that we have to test for sure the embryo quality. If we don't test for embryo genetic quality, then it's useless all the discussions. And I can very strong support that in the near future, after 10 years, I think no one will perform embryo transfer with untested embryos. We will find the way to perform secure genetic analysis of the embryos. I'm definitely sure for it. So within the next 10 years, all the transfers will be based on, first of all, genetically tested embryos. The second very important for me is hysteroscopy. And you have to remember that many reproductive physicians are also trained in hysteroscopy and laparoscopy. So you cannot guarantee on the judgment of your private gynecologist. You should trust the opinion of a specialized fertility specialist that he's also an endoscopist, that he knows how to do laparoscopy and hysteroscopy. Not all the fertility specialists, they have experience on this. And the third very important thing is the testing of endometrial receptivity. We have some genetic tests developed the last 15 years. So look into the implantation window, but it's not only implantation window, it's also, as I told you, the endometrial microbiome and also the immune profile, specifically the NK cells of the uterus, of the endometrium. So let's talk about preimplantation genetic testing. Of course, it's not an ideal tool because you always harm the embryo. But it's another thing to harm it a little bit, and it's another thing to damage it completely. So, for the moment, keep in mind that in experienced hands, only 5% of the embryos are damaged because of the biopsy. So, the real risk is 5%. The problem is that as patients, you are ignorant which centers they really are experienced on accurate and safe biopsy technique. So before you choose, once you have an IVF failure, after failure, you have to find a center that they really do a lot of PGT and not to trust someone that you can see during the consultation that they don't support it. If they don't support it, they don't believe it, they don't do it. Keep that in mind. So in order to avoid more than 5% of risk of damaging your embryos, you have to find the right clinic that they trust and they believe in the testing of the embryos, so they perform it as more appropriate as possible. So we do actually karyotyping of the embryo. The problem is that we karyotype the placenta, the trophectoderm, we don't touch, and also this is the advantage that we don't harm the inner cell mass that will become the real human. So when someone says that we might produce abnormal humans, it's completely ignorant. We test the placenta, so the problem is that the placenta is not 100% reciprocal to the inner cell mass. So that's why we have this situation that we call mosaic. So some cells are normal, 46 chromosomes, and some cells are abnormal. However, now we have developed algorithms, and almost 65% of the mosaic embryos are suitable for embryo transfer, and in our clinic we have 33% delivery rate just by transferring mosaic embryos. So the results are excellent. None of these babies have been born with a genetic defect. So it seems that the algorithm looks excellent, and this algorithm has been developed from the genetics, from the European Society of Reproductive Geneticists. So it seems that this algorithm works well, so we're not losing embryos. And of course, you have to remember that once we transfer a genetically tested embryo, the chances of delivery are 48%. So it's like doing egg donation. As I'm telling to my patients, once you have an euploid embryo, we call it euploid one once it is 46 chromosomes. So as I used to say to my patients, once you have an euploid embryo, you are acting like being 25, like doing egg donation with a 25 donor. You should expect from us to return you a 48% delivery rate. So this is the ceiling of IVF. Nothing is more than 50% delivery rate. And of course, it is a problem, the cost, but in our clinic, it's not so much. We charge 1,000 for the biopsy and only 300 for the embryo testing. And you can see that after the age of 39, after the age of 40, almost all 60 to 80% of the embryos are abnormal. So when I'm above 39, it's completely wrong not to do IVF with preimplantation genetic diagnosis. It's useless. I get no information. So if I fail, I have to fail because it's not a real failure. This embryo transfer should never take place. So keep in mind that after 39, 60% of the embryos are abnormal. And at the age of 45, almost 90%. Abnormal. Hysteroscopy. Also here there is a lot of discussion. Many clinics, like in Netherlands or in Sweden, they don't trust hysteroscopy, so they think that all the uterus are normal. I can tell you from my experience that once I see a normal uterus in my clinic, especially after a failure, it's very rare. Maybe only 10% of my hysteroscopies are normal, completely normal. So almost 50% of the ladies that we do hysteroscopy after multiple failures, they have what we call arcuate uterus or septum grade 1. I can tell you that we fight many years in our congresses to convince other doctors that arcuate uterus is not a normal finding. You can have a normal pregnancy, you can have a term pregnancy, but it's not normal. Only a minority of patients they have arcuate uterus, not all of them. So it's not a physiological alteration. It's the minimum of septum. So now after the last classification, the arcuate uterus is considered as septate uterus grade 1. So what we do always uterine incision of this fundus, and we restore the cavity to the Greek delta. It's like a delta, the uterus. Otherwise, when you have this arcuate, it's like a heart shape. So we make it straightforward. So it's not a real scratching. This is a fundus incision with the hysteroscope. So we have shown also with meta-analysis that once you perform this in egg donation, you have 10% higher pregnancy rate. As I told you before, we do also 3 other tests. We test for implantation. We do initially it was developed from EV, iGenomics. So we are very happy that these colleagues from EV Spain, they put a lot of effort to make the first panel, genetic panels, to find if my window, because there was a study back to 57 from a Greek scientist in the United States. He was a pioneer on uterine receptivity. He showed he was the first one doing microscopic examinations on rotans that the endometrium is not always receptive. It opens around 5 days after ovulation, 7 days after a late search, and it stays open for 3 to 5 days. So this is the mechanism of protecting women not to get pregnant easily. Especially, you have to remember that in the ancient years, the women were always the victims of rape during war. And war there was every year in front of my door. You woke up a day and always a foreign people that was attacking your house. So actually, our endometrium is irreceptive the 25 days, 24 days of our cycle. So it's very limited, the real receptivity. That's why we call it window. So in order to protect us for unprotected intercourse. So with this test, we can see if, with this window. Also, very important is endometrial microbiome, because if we have less than 70%, the tests they are telling about 90%, but I think that it's very high, this percent of lactobacilli. So if I have less than 70%, then it seems that there is a problem. When I have less than 50%, definitely my uterine lining is infectious, so I have to cure it. So although in the beginning also I did not trust this microbiome. Now I can tell you that I have changed my mind, and I always test it. And I can show you here, for example, the huge difference when it was a non-dominant lactobacillus endometrium, only 20% they got pregnant compared to 60%. This was after transferring single blastocyst. So 60% with lactobacillus dominated flora and only 20%. When you have such results, how you cannot trust them? Okay, so another test is, as I told you in the beginning, the natural killer's phenotype of my endometrium. In the past, there was another test in the blood. This was completely nonsense because the phenotype of the natural killer cells in the blood has no connection with the natural killer's profile in my endometrium directly. So now we have developed such test, and I can tell you that especially in repeated implantation recurrent pregnancy losses, then I always take it into consideration, and I give higher doses of prednisolone. So, as I told you, as I just mentioned now, especially when we have miscarriages or we have an altered NK profile, then we give corticosteroids. Also, when we have thrombophilia, we should give either aspirin or heparin. Some of hematologists, they propose both of them. I'm not so sure that we should administer both of them, but if we have real thrombophilia, we can give heparin. On the other hand, as I'm explaining to my colleagues, because many of them they don't believe it, when we do frozen cycles, so we give extremely high dose of estrogens, then we should give aspirin to protect these patients, these women, from heart infarct or from brain stroke. So you always have to be careful. So we don't give aspirin only to increase our chances of implantation. We give it as a protector of blood clotting for our patient. Progesterone support. Also, we know that some vagina, they don't absorb the vaginal capsules correct. So that's why we should always test progesterone before the embryo transfer, and once we see less than 10 or 12 nanograms, then we give always extra subcutaneous progesterone. Growth hormone. There are very small studies that they support that it might help. Unfortunately, in the majority of the countries, is not available. Intralipids, it's another story. I think for just IVF failure, it doesn't help, repeated IVF failure. But when I have repeated pregnancy loss, I always administer this. And of course, it's not only medication, it's also about diagnostic tests. So how we can talk about repeated implantation failures if I have never tested the fragmentation, the DNA fragmentation of the sperm of my husband? Many physicians ignore the male factor. They think that because we perform ICSI, we sort out all the problems. This is not true. So I think even if the sperm is low, less than 5 million, we shall always test, even from the beginning, the DNA fragmentation. And of course, I believe that karyotyping of both parents should always take place even from the beginning, not after failure. It's only 1 to 2% that might have a problem in our 1%, not 2, that might have problem in my karyotype, but this 1%, I think, should be recognized, identified straight away before the start IVF, because now we have the result within 3 weeks, and it's very accurate, it's not expensive at all, and now many insurances, they cover it. Last, reproductive immunology testing, I think, should always take place if we fail more than 3 IVF or if we have recurrent pregnancy loss. So, everybody talks about personalized treatment, but actually it's also a marketing phrase. So, to get personalized treatment, you should refer to someone who knows how to personalize because he's experienced. So everybody speaks about lifestyle modification, but how can I treat my husband with supplements when he doesn't quit smoking? It's completely nonsense. Also, to optimize embryo transfer conditions, this is also important, and generally the advanced lab environment, the patients unfortunately cannot be sure that the lab environment in a clinic is excellent, but as the owners, we should be extremely careful and responsible for offering you a perfect environment. And so that's why I'm really serious when I'm telling that when you refer to a clinic that is under the branch of a fund, actually it's just an economist that he's running the clinic, that he's completely ignorant of what's going on into the lab. Once a doctor or an embryologist own both together a clinic, then it's impossible not having a perfect environment because you care for this environment, because you care for your baby, and the baby is your IVF clinic. So for others, it's just money. So be careful when you select big brands under funds. So supportive care, I said before, it's also important to not to lose your courage and to really try to find the answer. And sometimes, as the fertility specialists, we should not be so egoist to consider a second advice from an hematologist, from an endocrinologist, and from a more experienced from us endoscopists. So the more eyes, the better the outcome for you. So these are the references. I think that I gave you some ground for questions. And Caroline, let's move to the question session. Thank you very much for having
Brilliant.
me.
Thank you so much indeed. It was very interesting. Lots of details, lots of important messages for sure. And we will go for your questions. So if you have any, there are some questions in the chat already. Please type them in right now. We have about 25 minutes for the questions. So don't hesitate. Okay, we are definitely here for you. And before we go ahead with the questions that we have in the chat, in the meantime, I'd like to also ask you, because you mentioned the importance of PGT-A testing, and I would like to ask you, because of course nowadays we also hear more and more about non-invasive PGT-A testing. Any comments on that? Have you been able to already use that or try this at your clinic?
We are in the process of testing the non-invasive. For the moment, it gives a result only to 60 to 70% of the embryos. So actually, you can only use it to prioritize the embryos. So actually, you have to transfer all of them.
Mm-hmm.
So even if I have 40% of not result, I cannot throw them. So I think that non-invasive in combination with artificial intelligence in the next 10 years will replace the invasive, unless the invasive will take place with another way. For example, we have to make it more perfect, just to inject and aspirate the blastocylic fluid, and through the fluid to make diagnosis from
Okay.
the inner cell mass cells that they are apoptotic into that fluid. So for me, this might be a future for minimal invasive.
Okay.
So
Thank you so much.
For the moment, non-invasive is just for prioritizing, and for some clinics for marketing, of course.
Course. All right, thank you so much. Just wanted to ask you because, of course, it's more and more about that out there, of course, in the fertility field. So I just wanted to ask you about it. Also, one more thing.
It will be the future, Caroline, but it still needs some years. Definitely, 2025 were much better from 2020. Definitely.
Obviously, definitely.
It has
Thank
been
you so much.
much more improved.
Thank you. And one more question before we go for your questions. You already mentioned about microbiome testing as well, and I wanted to ask you about the tests. Is it Emma, Alice that you are using, or there are some other, of course, tests on the market, in the market? So, are you able to tell us what kind of tests you are using and you think are, good?
We do our own. We're doing our own NGS testing. So either from Illumina or the reagents are from other companies. So the new machines are very, very strong. So the new microbiome tests, I think they're quite accurate. The interpretation, as I told you, for me, it might change in the future. So I think this 90%, I think is too much. So you see patients losing their faith or getting terrified, but seeing that I have 75 lactobacillus, I think that 75% is normal for me. But less than 50% is definitely abnormal.
All right. Thank you so much for the clarification to this as well.
And also, Caroline, as we discussed 1 month before ago, you have to repeat it, because it does not mean that I took treatment, so I'm cured. So although it has a cost, I think we shall repeat it, especially if we have more than 3 IVF cycles. Forget about the 4 embryos, but after 3 IVF cycles, I have to do anything.
Right.
And to be sure before I transfer my precious blastocysts, especially when they are tested.
Exactly. All right. So after the treatment, probiotics treatment, it's better to actually repeat it before any transfer.
Repeat,
Right?
definitely.
Brilliant. Thank you so much indeed for those. Now we will go for your questions. There are some questions in the chat. I can see some people are already typing as well. So let's get going with those.
They're
I'm really
welcome.
curious. And let's have a look at the first question from Kate. So I'm currently taking prednisone for high thyroid antibodies. Would intralipids be better option, as I find the prednisone is causing a lot of fluid retention? Anything you can advise here?
Kate, unfortunately, the good medications, they have also side effects. No, I think that intralipids has nothing to do with this, and you should not discontinue your prednisone. And once you do embryo transfer with a tested genetic embryo, if you are in the category that I just mentioned before, recurrent pregnancy loss or multiple IVF failures, not only 4 embryos, more than 3 IVF, then you can do also intralipid. And we do intralipid on the day of the embryo transfer, and once we are pregnant, once every week until the 9th week of the pregnancy. So you should not take it for always. But also we should not forget that corticosteroid is a magical bullet.
Okay, thank you, Kay, for your question. And let us know if there's anything else. I do hope it was helpful for you. And let's have a look. More questions are coming in, so let's have a look at the next one. Uterine NK are required at optimal level during inflammatory phase of implantation. How can we assess the pathological level during window of implantation?
There are two types of endometrial NK cells, CD56 positive. So we do phenotyping. So some companies, they have developed this phenotyping. You do a uterine biopsy. So actually, what we do, if we do also implantation window testing, at the same day we take three different species of endometrium, one for the window, one for the NK cells, and one for microbiome. So the patient has to come only once to the clinic. Okay, so window, I don't do it so often. I don't believe it so much, but definitely in the future might be improved. The other two tests, I always do it together, microbiome and NK cells phenotype.
Okay, brilliant.
And your
Thank you.
doctor is responsible to make the reading of the results,
Of course.
not yourself. Of course, you can put it in ChatGPT. So this year might give an answer A. After 5 years, we'll give an answer B, ChatGPT.
Sure.
And I think after 10 years, the answer C will be much closer to reality because medicine is always improved.
Yes, that's true. Thank you so much indeed. All right. All right, next question is, so is it advisable to take probiotic supplements when trying to conceive? If yes, which one is recommended?
Probiotics, I'm not sure. I think it's too much. But if I want to take some supplement, this supplement normalize when my food intake is not appropriate. If I'm working many hours, if I'm not taking the night portions of meals, I think taking supplements and not probiotics might be encouraging of even spontaneous conception, not only IVF outcome.
And can you name the supplements that are most common that are advisable?
I can comment only on pregnant care that are the first in the market. So they're not expensive, and I really think that since they are the first, they have a lot of experience. So also we should be cautious because many supplements are very expensive just for adding nothing.
Okay, true. Thank you so much indeed. All right, let's have a look. Okay, we have some information here as well. I have had 2 biochemical pregnancies using donor eggs, just had my microbiome tested, and the lactobacillus was 1.21%. Could be this reason, could be this the reason for the chemical pregnancy.
Nadine, it's I never experienced less than 10%, so 1% is a dramatic result. Definitely might be the reason, at least for one of the two. The other one might be an abnormal embryo. Always keep in mind that taking donor eggs does not mean that they are genetic normal. So the donors, if they produce maximum 3 or 4 genetic good eggs. If by coincidence these 3, 4 eggs they are taken from another couple, from that specific stimulation, I will never get pregnant. It's so simple, the explanation of not getting pregnant with an egg donation. So I think 1% is very, very low, and I don't believe, Nadine, that you will able to make it never 90%. So if you ever have it 60, 70%, feel safe and proceed.
Okay. Thank you so much again. I do hope it was useful for you once again. Elena has another question here. How do you test uterine microbiome? In which day of cycle? How long does it take till results? And how much is the test?
As I told you before, we try to take this test during the implantation period, okay? So, and also the endometrium is thicker, and also we can take more specimen for the analysis. So immediately after the period, I think it's not a good idea because still there are a lot of germs in our vagina. So I think it's better to take it after ovulation, okay?
Mm-hmm. And are you able to tell us how much is this?
Also we like scientific evidence if there is a correct day to test for this.
Right. Okay. And are you able to tell us about the costs, more or less?
For our clinic, we charge it around, if I remember well, $500, something like this. So it's not really expensive anymore.
Okay. Thank you so much again for that. And of course,
But you can find also with Chinese reagents with $300.
that's true as well. Thank you so much indeed. Okay, we have more questions coming in, and let's have a look at this. So for 45 plus patient, if NK cells around 18% and only one good embryo to transfer, no failed transfers and few chances for more embryos, would IVIG or intralipids be recommended to improve chances? If so, which would be more appropriate?
The intravenous antibodies, I will not recommend. There are many trials in the past that they have shown no real benefit. Intralipid, I would go more for intralipid. It's more safe, less expensive, and it seems that alters the immunological profile of patients. So I would go for intralipid.
Okay. Anything else you would like to add, Teg, let us know. I hope that was useful for you as well. And let me just go to the next question that we have here from Ellen. So 3 miscarriages, 1 failed IVF transfer, euploid on immune protocol. I will have my hysteroscopy next week. May I ask what's normally the test done during the procedure? I was only told about biopsy, but not sure if there are other tests that are recommended. I had a uterine CS, which is negative. Anything you can advise here?
CS, what is uterine CS?
I'm not
Because
sure, I'm sorry, but
it's not cesarean section. I had a uterine CS.
exactly. Ellen, if you can, culture and sensitivity, which is negative. Uterine culture and sensitivity.
Negative.
Yes.
I had a uterine CS. It's not microbiome.
From
So
uterine biopsy. This is the message Ellen has added.
anyhow, I think that even during the hysteroscopy, even if he finds nothing, your doctor or she, they should perform uterine scratching, but scratching in the process during in the meaning of doing the endoscopic fundus incision. Okay, so this is the real scratching of nowadays. And also you should test your uterus for microbiome and NK cells phenotype, 100%. Immune protocol, I don't know what it means, immune protocol. Maybe she got corticosteroids, she means, maybe. I have never listened to this immune protocol.
Okay, well then if there's anything else, any follow-ups, you know what to do, go ahead, type this in, okay? But I guess that was already useful for you. Thank you for that. Let's have a look. Maria would like to ask you. So, I'm using donor X because I'm 45, failed 3 times. I can now do PGT and I was thinking about hysteroscopy. Am I taking the right approach? I was told once by the technician I have a heart-shaped uterus, but my fertility doctor didn't see it as an issue. So could I get a hysteroscopy at your clinic then?
Maria, I can tell you that a lot of my colleagues that I really respect, still, they don't believe on arcuate uterus. I'm 100% convinced, Maria, 100% convinced. As I said also and conveyed in the previous session like this, every year I have 5, 6, 7, 10 patients that they do hysteroscopy. We do just scratching of the fundus, and they got pregnant spontaneous, and they have their embryos still in the fridge. So how I cannot be convinced? The thing is that not all of us, they know how to do hysteroscopy and how to interpret the uterus. So even if you don't come to us, go to someone that he knows how to do the real hysteroscopic fundus incision.
Definitely. Okay. Thank you so much. And of course, if you like to get in touch with Professor Papanikolaou and his team at Fastest in Nature, you can either get in touch with me or through their website directly. I'm sure they will be also able to and happy to help you. So please note that. And let's have a look. Possibly our final questions. So if you have more questions, please go ahead, type those in right now. This will be the final call for the questions. And this is the question that we've got. So I had a second trimester loss without any specific symptoms or abnormality, just cervix opened up. Does that happen due to any specific reason? What are the tests to be done before next cycle and transfer?
So second trimester, it's another story, okay? So second trimester, it might happen for other reasons. So definitely, it's another story if you had spontaneous initiation of labor. So this is a real miscarriage, okay, because the embryo just expelled from the uterus. So in that scenario that the embryo was alive and we had rupture of membranes and the amniotic fluid came out, you should test the uterus for congenital abnormalities like septum, okay? Or you did not interpret spontaneous contractions of the uterus, so you have to take extra progesterone during this second trimester. So it's another story, and also 100% you should test vaginal and uterus for germs because it might start as an infection. If the embryo had died before, so it was a missed abortion of second trimester, this might be a genetically abnormal embryo or has a metabolic syndrome. So if you have deceased siblings in your families with whatever reason, maybe you can do an exome sequencing to test your full genes for a rare genetic disorder that both of you might be carriers. I'm just giving some interpretations, okay?
Okay.
Or
Thank
it
you
was
so much.
just a simple demise of the fetus because the placenta did not work appropriate or the umbilical cord had a real knot. These things might happen, okay, sometimes. So it's two different stories, having an embryo that is already died, and it's another story when the embryo expels. It's getting expelled from the uterus.
Okay. Thank you so much indeed for that. I do hope it was useful. I do believe so as well. As I mentioned, looks like that was our final question. So thank you everyone for your questions, for your time, Professor Papanikolaou. It was lovely to have you. I think we will finish for today, but of course, remember, as always, if you have more questions, we are here. We are definitely happy to help. So you can either email me directly and I'll be happy to forward any questions to Professor Papanikolaou, or you can get in touch with the Assisting Nature team.
And our email, Caroline, you have our email is international@assistingnature.gr.
Yep, exactly. So you can always use that email address as well. And yeah, I can see some thank yous coming up your way as well. So we should invite you again. This is one of the comments. So I agree, totally agree. So thank you so much, everyone. It was
For
great
another
to be here.
more easy topic next time, because this topic we can talk and
True.
fight with colleagues for days, not for
It's
evenings.
true. It's definitely not an easy one, but I'm really happy that we were able to discuss this once again, because I think that we should talk as much as possible, even though we are repeating those topics. It's definitely needed, and we appreciate you joining us today as well. So thank you so much, everyone. Remember that we will be back actually tomorrow. We will talk about mosaic embryo, so I can only encourage you to join us tomorrow. Professor Papanikolaou, looking forward to some more events with you. Thank you so much for today, everyone, as well. Have a lovely evening, and hope to see you soon as well.
Take care.
Take care.
Bye-bye.
Good night. Bye.
Good night.